All right, so we were kind of working on this particular objective last time. We didn't quite make it all the way through. So we want to know what parts of the upper respiratory is commonly infected by Streptococcus pneumoniae and Haemophilus influenzae. And so although you don't breathe through your eyes, right, your eyes, a pink eye infection could be caused by either one of these bacteria. And the reason why we talk about it now is because it's linked to your nose, to your respiratory tract, right, by the duct, your tear ducts or your nasolateal ducts. Same thing with your ears. You're not using them to breathe, but they are attached to your nasal cavity. And same thing with your sinuses. You're not breathing through them, but they're connected to your nasal passages, and your sinuses are cavities within your skull. So we don't really think of them when we think of upper respiratory per se infections, but these areas usually get infected through our nose, right? Through those linkages. And then there's many other offenders other than just these two guys that can cause infections, and we'll talk about, and we have talked about some of these guys already. And then also don't factor out that viruses can cause these types of infections too. So we were talking about some of the particulars with the symptoms of pink eye and sinus infections and inner ear infections, and some of the treatments that they do for these types of infections and why children experience them more often, especially for the inner ear, than adults because of that pitch of the eustachiary tube. So epidemiology-wise, a lot of us are carriers of Haemophilus influenzae, that bacteria, as well as Streptococcus pneumoniae. Epidemics are very common for the pink eye infection among young children, and again, generally crowded environments and people not knowing proper hygiene, right? Little kids aren't very hygienic, unfortunately. Usually when you have older children, right, we know and how to avoid the spread of disease, where little kids don't think about that. And then we talked about how it tends to be very young, and they believe that at one time the major offender is Haemophilus influenzae as far as the ear infection problem for young children, other than the anatomy problem of the pitch of their eustachiary tubes. And so that's one of the main reasons for the vaccine that we talked about against that. But again, tough to get data to really prove how effective the vaccine is against particularly ear infections. Sinus infections tend to occur in adults and older children, and again, due to the development and changes that happen in the sinuses in this case, it's worse for us as we get older. They enlarge, right? There's more space for infection to potentially happen. So prevention and treatment for pink eye, obviously, avoid touching and rubbing the eyes. Even bacteria or viruses that get onto towels can be spread that way, so you never want to wipe your eyes with a towel that maybe someone else has used. My son is so dirty with his towel, he has his own face towel in the bathroom, and then my husband and I have ours. Because, we're still working on some of those hygienic things, right? So treatment is usually achieved by eye drops or ointments that are put directly on the eye. Mostly we're dealing with for bacterial infections, right, that we have antibacterial drugs. For viruses and such, they can give you ointments and eye drops. Mostly those are just to soothe the eye during the span of the infection, not to eliminate the virus, right? We have very few antivirals that are effective against viruses. For inner ear infections, the go-to usually for that is amoxicillin. And this is a penicillin derivative, right? Notice the "cillin" at the end. And so for this one, and the flu vaccine has been proven to be helpful too for preventing ear infections, because the flu will damage your ciliated cells associated with your respiratory and all of that, and helping keeping mucus moving and moving fluid out of those areas. And it can reduce the incidence. But when we have a bacterial infection of the inner ear, the most common one is amoxicillin. So again, it's a modified penicillin. It's effective against gram-positives and gram-negatives. Oh, I don't have my description for that one. But, you know, if you look at the chemical structure of penicillin, the main portion is the same. It's the other sections that get modified when they chemically modify penicillin to make these other cillins like amoxicillin. Most parents have experienced this one that have had kids that have had ear infections. This is the pink stuff, right? The pink liquid, it tends to be given in liquid form. The good news is this stuff is dirt cheap. So, you know, if you knock over the bottle, your insurance won't pay for another one, but it's like $3. The pharmacy, right? Been there, done that. A lot of the penicillins are really relatively inexpensive drugs. They're not very difficult to manufacture. So then that brings us to viruses of our upper respiratory. And this is, you know, mostly the colds that you experience, the common colds, right? And so what would be some important strategies to help avoid the common cold? Avoid people with the cold, absolutely. Wash your hands. Get you some Lysol, right? Be clean about it. So this virus attaches to your these viruses, there's numerous viruses. That's why there's never probably any hope for a vaccine, because when you have a cold, it can be any number of many different rhinoviruses, rhino referring to your nose. And so, you know, the upper, you know, our head region, our nasal passages, our throat are usually what are most commonly affected by the common cold. And then among the many different rhinoviruses, there are several different types within the viruses, right? So when we talk about bacteria, we talk about different subspecies or different strains. Well, when we talk about viruses, it's different types, right? So even with HIV, most people don't realize there's actually two different types of that virus out there, type 1 and type 2. There's actually two different HIV viruses. And of course, you know, there are some colds that can caused by bacteria as well, right? But most commonly when you have what we call the common cold, when you have that scratchy throat, the nasal discharge, the fatigue, the malaise, the headache, the cough, it's usually some virus of this grouping. And they attach to your respiratory epithelium. Remember, that's the first thing for all infections. They've got to be able to attach to you. And especially for viruses, that's not enough. They get attached and then enter into your cells. And again, that attachment process is usually pretty specific depending on the virus. So in this case, these viruses, the reason why they cause the congestion and everything like that is they've adapted to be able to attach to receptors found on our epithelial cells, our respiratory epithelial cells. So that's why they're causing that damage in that area. It can spread to adjacent cells, right? Once it grows in one cell, it busts out and spreads to other cells. The ciliate action, the ciliated cells that help move the mucus, ceases, and the cells will even die and slough off, right? Mucus secretions are actually increased, but when you don't have the ciliated cells to move it, right, you get the buildup of mucus, you get that congestion, you get inflammation because you do have an infection. And again, remember, interferon can help interfere with the spread of viruses. It's released by our cells. It's one of our cytokines. And then we have cellular immunity. So when we talk about cellular immunity as far as our adaptive immune response, what cells are we talking about? What cells are going and killing virus-infected cells? What leukocytes, what white blood cells are our adaptive immune response? Specialized lymphocytes. What are our lymphocytes? Natural killer cells would work. Cytotoxic T cells, right? And then the humoral immunity response, what do we refer to? What's the product that helps protect us against viruses that our humoral immunity is producing? What's humoral immunity refer to? What are we producing? B cells make them. Antibodies, right? So this can attach to the viruses before they attach to our cells, neutralize them before they get in, right? So your response against viruses can be multifaceted, right? So we are really good, although it'll take us time sometimes to be really effective against specific viruses. So you can inhale these infectious respiratory droplets. So transfer of the mucus, right, to the nose or the eye, because remember the eyes are linked to your nose, right? Rubbing your eyes, never a good idea. With your contaminated fingers. Children initiate outbreaks in families, again, because of lack of care with these nasal secretions that they have, right? They don't realize how yucky boogers really are. So to help protect ourselves, right, we want to wash our hands. We want to avoid people with colds because obviously they have an infection. We don't want to get it. We want to avoid touching our face. Anywhere it can enter in. We don't want to touch our eyes, our nose, our mouth, right? No general accepted treatment except for controlling the symptoms. And even then you want to watch out and not necessarily take anti-inflammatories because you need that inflammatory response, right? Sometimes to get rid of these invaders. So no vaccine, like I said, it's just not practical, right? There's just too many different viruses out there. So our best area is prevention. There are some more antivirals being available out there now for helping actually treat viral infections, right, to help with cold symptoms. Again, avoid the ones that inhibit inflammation though, right? You don't want to be taking ibuprofen. So there's a particular group of viruses, your adeno, like referring to your adenoids, right? Viral pharyngitis, again referring to your throat being inflamed. And so for these particular group of viruses, the distinctive symptoms, the difference here is that you'll have fever and sometimes pus on the tonsils and the throat. And this isn't something normal of a viral infection, right? And they multiply, they destroy our cells, and this is what produces the different types of symptoms that we're not used to seeing with viruses, right? Pus and such you're usually used to seeing with bacteria. So there is a live vaccine formerly used by the military, but it's no longer produced. Again, it's not a major problem. And again, no accepted treatment except, we just control the symptoms until your immune system gets it under control. They believe it's infectious respiratory droplets, but it could possibly be also spread by gastrointestinal tract, right? So coming in contact with fecal matter. Human-only source of infection. And again, we see sporadic outbreaks when we have people that are exposed to large groups of people in winter and summer months, right? Winter months when you're all huddled up together, spring when you're out doing large group activities. And the epidemics could be from people being asymptomatic carriers, right, where they're carrying this virus, they're not sick, they're not showing outward signs, right, and they're spreading it to others. So in your book lists several lower respiratory system infections, and so we're going to focus on just the top three here for the bacterial ones. But most of us are familiar with influenza, right? Some of you guys have heard about hantavirus syndrome. And there's several fungal infections that we're seeing more problems with, especially people who are immunocompromised, right? Who have HIV type infection. And so if you go to the CDC's website like we did before, you can see how they track a lot of this stuff. Legionnaire's disease was actually discovered or named at a time period when there was a meeting of a group of individuals. I know it's Legionnaires, but there's something else to the name of the group of veterans, military veterans. It's an organization. And so it kind of got named after them. And it contaminated a air conditioning system, And that's how the people at that particular meeting got infected. And so one of the interesting things about that one is that it really took us a long time to be able to produce the particular conditions in the lab to be able to grow and test and properly diagnose people with this type of infection. And so when we look at the epidemiology, it's like, well, is it actually increasing the number of instances, or are we just gotten better at detecting the presence of this particular organism causing this particular infection? So really, it's only going to be time that tells us, right, if it really is an increase in the incidence, how many new infections, or if we've just gotten better at detecting it. Okay, so if it continues to climb, then we've got a serious problem, right? Because it's just going up and up. If it plateaus at some point, it's probably that, we got really good at testing for it now, and it's at a particular level of the population. So pneumonia, there are several different types of pneumonia. We've already talked about pneumococcal pneumonia, right, caused by streptococci. Klebsiella pneumoniae and Mycoplasma pneumoniae are the three top causers of pneumonia, which is an infection of the lungs. So we have an excellent table in y'all's book that does a good job of listing all the major components of them so that it makes it easier to compare and contrast them. And so many of these other slides I'm not going to go through today. But they're just detailed information on the summary, I guess you could say, that's here. So notice incubation period. So this is a period when it's growing inside of you. You may even be spreading it, but you're not showing outward symptoms just yet. So relatively short incubation period for pneumococcal pneumonia, right, caused by streptococci pneumoniae, 1 to 3 days. Same thing with Klebsiella pneumoniae. Where with Mycoplasma pneumoniae, 2 to 3 weeks. And this is why this one has the nickname of being called walking pneumonia. Because usually people are up walking around, right, and don't realize that they're sick, right, that they have a serious infection. So major differences between the bacteria themselves. You have an encapsulated strains, right? So they have a capsule. This helps with their virulence for Streptococcus pneumoniae. Same thing is true for Klebsiella pneumonia. One of the defining characteristics of Mycoplasma pneumonia, we've talked about this one before, it lacks a cell wall, right? This particular bacteria does not have a cell wall. So of course we usually look at symptoms, right? We're not going to be able to necessarily see the bacteria, right, unless we take samples and run tests. So mostly what clinicians are looking at are the particular symptoms. So definitely with walking pneumonia, the gradual onset of illness is a pretty good indicator that you're dealing with Mycoplasma pneumoniae. Where you've got a relatively fast onset for Klebsiella pneumoniae and pneumococcal pneumonia. So what are some differences when we compare these? So they both got cough, they both got fever, right? But the difference comes into play with the type of sputum, the spit up, you could almost say, that the people experience. So notice for pneumococcal pneumonia, it's a rust-colored sputum, and the reason for that is the degradation of red blood cells, right? Shortness in breath, pain in the chest. Where with Klebsiella pneumoniae, it's more of a glossy bloody, so we're not necessarily destroying the red blood cells, right? But we have blood in the sputum. And mucoid, very, very thick mucousy sputum. And the difference has to do with the type of organisms that we're dealing with. So for streptococcal pneumoniae, as I said, encapsulated bacteria, they cause an inflammatory response. Plasma, right, blood and inflammatory cells fill the alveoli, right, our air sacs. And this is where you get the pain really associated with this type of pneumonia. Where when you're looking at Klebsiella pneumonia, aspiration of the colonized mucus droplets from the throat, that's the mucoid component. Destruction of lung tissue, you even can get abscess formation is common. So that's why you're getting blood, right? Because you're actually getting damage to the tissue. This is actually one of the worst ones. You think pneumococcal is bad, Klebsiella is pretty darn bad. And then it gets even scarier when you talk about Klebsiella pneumoniae, is that this organism tends to be resistant to a lot of antibiotics. And so therefore, people who are taking antibiotics can even get this infection, be colonized by this organism. And so in hospital settings where people already have weakened immune systems, in elderly housing, right, where you have a lot of people that are elderly, so their immune system is waning, this can be fatal, right, if not diagnosed properly and treated properly. So notice they'll give multiple drug therapy for this one. They list 2 types of drugs, 2 types of antibiotics that they would give an individual with this type of infection.
My daughter had that.
Your daughter had it?
I think they put her on vancomycin to start with, and then they gradually moved her down. She had her lung actually collapsed. They got to that.
Yeah, it's pretty frightening. The good news is that they diagnosed it properly and treated her quick enough that she didn't die.
Yes.
It's pretty frightening stuff. High carrier state for Streptococcus pneumoniae, for this pneumococcal. It increases when you using alcohol. Alcoholism damages your respiratory tract, believe it or not, and interferes with the ability of the ciliated cells to work. So does narcotic use, so does smoking, right? It interferes with the ciliated action, and because of that, right, we're not able to move this stuff up out of our lungs, and it gets down into our lungs and leaves us more predisposed. Chronic heart disease, diabetes, cancers, right? Number one killer of people with HIV that have progressed to AIDS is pneumonia, right? So it isn't the AIDS that kills you, it's the fact that the AIDS has eliminated your immune response, right? And some other infection gets you. So we talked earlier about a vaccine that covers 7 different types that's commonly given. They have a newer one now. You hear it advertised a lot on TV now, Prevnar 23, and again, in this case, it's against 23 different capsular antigens associated with these bacteria, Streptococcus pneumoniae. Because it is a gram-positive bacteria, and we don't have any cases of antibiotic resistance, things like penicillin for people who are allergic to penicillin is very effective. And then remember, erythromycin is the go-to drug for people who are allergic to penicillin. It's the alternative that we tend to give. And this has a completely different action, though. It's interfering with ribosomes, interfering with protein synthesis. No vaccine, right, for walking pneumonia. Again, you usually only see this in crowded places where it gets spread. You have outbreaks of it in schools. When I was in college, living in the dormitories, one of my friends got it, where you're in close contact. And again, we can treat with antibiotics, but we're not going to be treating with antibiotics that target the cell wall, right? Because we're dealing with something that lacks a cell wall. So things like tetracycline and erythromycin that have different targets, they're targeting protein synthesis, are effective against this bacteria. Right? So we look at things like incubation period, distinctive symptoms, right, to help us in the diagnosis. In treatment, being able to know what type of organism is causing it is going to help us in determining effective treatments. Knowing the prevalence of where you see these things and how to avoid them can be helpful. What is it actually doing, right? And the pathogenicity, what it's actually doing to your body, is directly linked to the symptoms that you see, right? This cellular destruction, right, is why it's bloody, right? This one, you're actually getting the degradation. you're getting a different type of action and inflammatory response that's happening. So you'll see a little bit different colorization referring to the destruction of blood being happening. So as I said, these are more of informational type slides for these guys. So I'm going to skip through them, but I left them in there for you guys. And we're going to go to pertussis, which anyone know the common name for this disease? Whooping cough. Yes, whooping cough. So it starts with a runny nose followed by a number of days of spasmodic, violent coughing. And this is quite a distinctive cough. It almost sounds like a whoop, right? Because individuals are coughing so violently that when they go to inhale, it almost makes a whooping noise, right? They're trying to suck in as much air in between coughing out, right? That they're really trying to get some air in. Vomiting and even possible convulsions can happen with it. The causative agent is Bordetella pertussis. It's a tiny little gram-negative rod. Notice the incubation period can be quite long, 7 to 21 days. Colonization is the surface of our upper respiratory and tracheal bronchial system. And so, it's going down into the lungs as well as upper respiratory. Ciliated action is slowed, right? So our ciliated cells are interfered with. Toxins are released that can cause death of the epithelial cells and by increasing cyclic AMP. So this is one of those energy processes in our cells, recycling AMP to ATP, right? It's a very important process. This is interfered with and so therefore really results in cell death. Fever, excessive mucus output. This toxin will also cause us to produce more mucus than normal. And the raise in the number of lymphocytes in our bloodstream when we test the blood. So again, we've got some type of infection, our immune system is going to respond, and specifically it's going to tend to be a lymphocyte response, B cell, T cell type response. How do we get it? We inhale infected respiratory droplets. Older children and adults tend to have milder symptoms, right? And therefore they're usually the carriers that are passing it on to the very young and old, where this can be a really serious life-threatening disease if not diagnosed and treated early. There is an acellular vaccine for this. Acellular means that they don't give you the whole bacteria. They're giving you part of the bacteria, right? So not a cell. We immunize our infants and children against it. And there was some gaps in immunization, and so it's been added in to the tetanus and diphtheria. So it's abbreviated TAPD now. T for tetanus, AP for acellular pertussis, and D for diphtheria. You had a question? TDAP. It's TAP, no D?
T, capital D.
Oh, okay, so they do the TD. Okay, so T stands for the tetanus, the D stands for diphtheria. Okay, DAP, DAP, gotcha. Okay, I was getting the order wrong. But that's what each of the letters stand for. So T is for tetanus, D is for diphtheria, the AP is for the pertussis. The A is to denote that it's an acellular vaccine. And there, do you guys remember what type of vaccine the tetanus and diphtheria vaccine is? It's actually not against the bacteria, it's against something the bacteria produce, the toxin. So those are called toxoid vaccines, right? Because they're against the toxin, not the bacteria. So erythromycin is somewhat effective if given before the cough gets to the spasm level, right, and will help eliminate the bacteria. So I said that characteristic whoop sound when they're trying to suck in air as desperately as they can. Gram-negative, so here they're actually showing a ciliated epithelial cell, And these are the bacteria in green here, specifically attaching to those cells. This one thankfully doesn't survive long periods of time outside the body, right? So you really got to come in contact with mucus or respiratory secretions from individuals, right? So basically somebody coughing in your face. The toxin is similar to what we talked about before with the diphtheria toxin, and that it is an A-B toxin, but this one is quite complicated. As you can see, there's many B components to it that bind to the surface of the cell, and the A component is what enters in, and as I said, interferes with the cyclic AMP cycle. It inactivates that regulation, and it will kill those cells. It also causes an increase in mucus production in your mucus-producing cells, and also decreases phagocytic killing by your phagocytic cells. Respiratory droplets, right? That's how you're getting it. Most infectious when you've got the runny nose period, right? When the person is, sneezing all over the place. Classically, like I said, major problem for infants. Milder form is seen in older children and adults. And so there's a major push, and some young parents and doctors are really getting hyped up about this lately. I had a friend of mine who was like, my friend won't let me see her kid unless I make sure that I've had the whooping cough, the pertussis vaccine. I said, she's being good to you too, because you should really keep up with that vaccine anyways. But, those of us, that haven't been kept up with our vaccines are the major contributors, right, to young children getting this infection and potentially dying from it. So again, it's been modified, right? It's a different abbreviation now that we've kind of figured out. So incidence, this is the most recent summary report, although it doesn't have the last 2 years. And this is an incidence. So this is, they're saying about 16 people per 100,000. So to give you an idea of actual numbers, in 2003, 28,000 people, right, were diagnosed with pertussis. Around the same number in 2014. So you can see that we've had quite an upward trend in the past couple of years. Hence, the action of trying to get people vaccinated to decrease the incidences of it. So reported pertussis has increased significantly. 2001, you can see that in the graph, to 6.1 per 100,000. In 2002, spiked all the way up to 15, close to 16 per 100,000 people. Several states experienced epidemic levels of disease, resulting in more pertussis cases in 2012, right? So they had 48,000 cases than we had seen in previous years, like back since 1955 was the largest spike they had, which was 62,000. The age, right, mostly the very young infants, right, that's can be the most damaging population to be affected. The second highest that they had seen during 2012 was the 11 to 14-year-olds. Followed closely by the 7 to 10-year-olds. As we said, and there it is, DAP, because Tdap, you could say it that way. So T for tetanus, D for diphtheria, and AP for the acellular pertussis. And so they've coverage among 13 to 17-year-olds continues to improve, right? Although we've had some difficulties, right, with getting people vaccinated. So it became recommended in 2012 that all adults under 19 years old, not previously vaccinated, get a single dose. And in 2012, pregnancy, it was recommended, was expanded for pregnancy to include vaccination among every pregnancy regardless of whether you had the vaccine or not. So this is the chart by age, right? As you can see, the largest numbers, around 5,000, right, in infants and the very young individuals, where it decreases significantly for older individuals. I guess I didn't, this is the latest summary they have, is for 2012. They don't have it yet. So what's the common name for the disease? Whooping cough. What's the causative agent? Bordetella pertussis, right? So that's where it gets the part of its name, the disease name, the proper name. Is it gram-positive or gram-negative? It's gram-negative. So again, that factors into treatment. List reasons why a capsule is beneficial to the bacteria. So this guy's encapsulated. Why would that be beneficial? Attachment. So as we saw, it allows it to attach to those ciliated cells. It also helps it avoid phagocytosis. Now, do you think it grows under anaerobic conditions? No, right? It's living in our lungs. It's very aerobic, right? Anaerobic would actually kill them. So what's the process? How does it make us sick? So the first thing that happens is it binds to us, right? It attaches, and then it starts producing what? What does it release that is going to cause damage to our cells? The toxins, right? It releases toxins. And it's the toxins that are the main contributors to the damage. So what type of damage do they cause? Right? They can cause cell death, but what are the major things that they also interfere with? They interfere with phagocytosis. The cyclic AMP, right? Which is going to increase what? Production. Mucus production. And remember, it also interferes with the ciliated cells, slows down ciliated cell action. So what's one of the distinctive symptoms? If somebody, that violent cough, right? That whooping cough, where they're really, just coughing, 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 and barely getting a breath in between. How is it transmitted? Mucus, respiratory droplets. Remember, what type of vaccine did we say this one is? This is acellular, so they're giving you part of the bacteria. So erythromycin is given to help treat this infection in the early stages. The drug is classified as a bacterial static. We talked about this before. What does that mean? What effect does it have on the bacteria? It inhibits it. It doesn't kill it, right? It's not going to kill it. So if it's just inhibiting it and it's not going to kill it, why would this be most effective when given early?
Because the bacteria don't have a chance to make more toxin.
Right. The cells you don't have as many cells, right? And you're going to slow them down. You're going to decrease toxin production, right? Early. And because then once you get to the toxic level, right, then we've got the problem with those toxins already being present. I'm not sure if they have an antitoxin for this one. And then you should never give bacterial static drugs to immunocompromised individuals. Why is that?
Because it can kill the good bacteria.
It could kill their good bacteria, but the other reason is, as we said, bacterial static. Is it ever going to kill the bacteria? No, right? So this person is never going to get better if we're never killing the bacteria, right? We've got to give them something to kill the bacteria, because when you take bacterial static drugs, what are you relying on to kill the bacteria that they don't have? An immune system. You're relying on your immune system, right, to take care of the next half. So the next one we have is tuberculosis. Actually, I think that's the last one, right? Good. Because I am getting short on time. But we've talked about tuberculosis before, haven't we? We have. All right. So let's see if we can, how many of these questions we can answer. The causative agent of this disease, mycobacteria tuberculosis. Is it gram-positive or gram-negative? It is gram-positive. What's the special stain in addition to a gram stain that would really help us pinpoint that we have a mycobacteria? Acid fast. Good. Can the causative agent grow under anaerobic conditions? No. Hence why, it likes our respiratory tract, right? Very aerobic conditions. A distinctive symptom of this infection. I don't know, a distinctive symptom. Yeah, again, a severe cough. But again, this is one of those gradual ones too. This is going to be a gradual onset. This is a long progressing disease. The means with which the disease is transmitted to humans? Again, respiratory droplets, right? You come in contact with somebody's mucus in droplet form. So it attaches to our respiratory cells, right? Even when we have inflammation, it gets gobbled up by the macrophages, but are they able to kill it? No. And then T cells come in, and we got this big clump of cells forming that we call what? Granulomas, right? And this is another distinctive feature, but you would have to do what to actually see this formation in the lungs? What type of test? You need an x-ray. You need an x-ray. Infectious dose. This is the minimum number of organisms you would have to be exposed to potentially cause infection. And this number is frightening. What is this number? 10. 10, y'all. Highly infectious disease. As little as 10 living bacteria, if you inhaled them, you could potentially end up with tuberculosis. So why is the vaccine not used in the United States? There is a vaccine.
Because it would cause the bacteria to be undetected if the vaccine.
Undetected by what?
The test.
The test, right. The tetanus, not tetanus, sorry. The TB test, right? Where they inject proteins into your skin. This is to see if your immune system has seen it. If you've been vaccinated, has your immune system seen it? Yes, so then your test is going to be positive because you've been vaccinated, not because you have the infection or have had the infection. Once positive, always positive, right, for the TB test, for the tuberculosis test. Determine why the duration of the drug treatment is so long for this disease. Why do we have to treat for so long? It's resistant to a lot of antibiotics. And so they're giving you usually combination drug treatment. And we have some strains out there that are what we call drug resistant. Then we have multi-drug resistant strains out there. And one of the major problems is that, for this type of infection, you're looking at 6 months or longer of antibiotics. And it's not always easy to keep people taking medication for that long of a period of time. And part of the reason for this is a slow grower. And the fact that it's hiding inside your cells, right? You can get inside your macrophages and grow intercellularly. So it's going to take much longer and be more difficult, especially when you have those large collections of cells, of macrophages and T cells forming those granulomas, that you could break down and actually get to all the bacteria, right? And until we eliminate them all, right, you still are infectious. You can still be spreading this disease, right? So why do we give more than one drug at a time? What do we say? Because there's a lot of resistance out there for mycobacteria. So again, most of these slides, go over just in a little bit more detail, but the main focus, right, is our objectives. I did put in this one, and I'll post it for you guys. As you can see, for incidence, 2012, yeah, Louisiana is one of the states where we have a high rate of infection. And they also compare U.S.-born versus foreign-born. Where is this coming from? Are we having the issue from people being vaccinated? A lot of foreign-born individuals are being vaccinated, and yet it's not a very effective vaccine. So it's one of the things that they keep track of. And I'll have the next stuff up soon. Oh, God.